Welcome to the Global Migration Centre Lecture Series podcasts. You are about to listen to the recording of Refugees in Times of COVID-19, The Challenges of Protection. This lecture was held to mark World Refugee Day 2021. The speakers are Vincent Chetail, Director of the Global Migration Centre, Dr. Madeline Garlick, Chief Protection Policy and Legal Advice of the UNHCR, and Dr. Santino Severoni of the Health and Migration Programme, Office of the Deputy Director General, World Health Organization. If you wish to keep informed about our activities, check out our website on graduateinstitute.ch/GMC or connect with us on Twitter, Facebook, and LinkedIn.
Refugees in time of COVID-19, the challenges of protection. Refugees have been affected by both the direct and indirect effects of the pandemic, and in too many instances, the rights of refugees have been compromised and their vulnerability exacerbated through discrimination, abuses, and exclusion. So the most vivid instances include obstacles in accessing healthcare, denial of protection because of border closure, rise of racism, stigma, and discrimination. But meanwhile, the COVID-19 pandemic has also highlighted the vital importance of building more inclusive and sustainable societies for both refugees and host communities. It is clear that the COVID-19 the COVID-19 pandemic has shown that we can only be safe if everyone is protected, including refugees, asylum seekers. And the COVID-19 pandemic also underscores the need for a truly collective response through enhanced international cooperation, because here again, no country can fight the virus alone. However, the overall picture of state policies remains highly complex and disparate because of the proliferation of unilateral and uncoordinated measures, and also as a result of TIS has impaired a truly coordinated response and compromised the rights of refugees. So the challenges of refugee protection in times of COVID-19, be they political, economic, humanitarian, or operational, are huge and manifold. Obviously, the first and most important challenge is access to protection. And from this angle, also because we will celebrate the 70 years anniversary in a few weeks, the Geneva Convention relating to the status of refugees is a key source of standard in order to ensure access to protection. And from this angle, border closure and suspension of asylum procedures are clearly in blatant contradiction with the Geneva Convention relating to the status of refugees. And UNHCR has rightly recalled since 1 year that denial of access to territory without safeguards to protect against refoulement cannot be justified on the grounds of any health risk. And I would add also that denying access to territory also goes in blatant contradiction with Article 9, the derogation clause of the Geneva Convention. This Article 9 grants state parties the right to adopt temporary measures in times of emergency. However, this provision of the Refugee Convention does not allow suspending asylum procedure. On the contrary, the wording of this provision makes it clear that access to protection remains plainly binding, even in such exceptional circumstances. And there are many other absolute guarantees under human rights law, in addition to the Refugee Convention, applicable in this situation and prevailing over any other considerations. For instance, the prohibition of collective expulsion, the best interest of the child, the principle of non-discrimination, and the continuing applicability of these key guarantees has been reaffirmed by many stakeholders, including, of course, UNHCR, but also the World Health Organization, IOM, the High Commissioner for Human Rights, UNICEF, and many others. In short, no public health consideration can justify a denial of access to a territory without proper safeguards to guarantee non-refoulement, best interest of the child, to protect against collective expulsion, and so on. Another key issue and key challenge relates to non-discriminatory access to healthcare and vaccination. And this is also another important issue to be addressed by states and discussed today. The pandemic has demonstrated the relevance and importance of universal health coverage, regardless of legal status and nationality. And clearly, the global pandemic is simply another example that no one can be neglected or compromised when it comes to access to healthcare. Access to healthcare is not only a temporary necessity in times of pandemic, but also a legal obligation under international law for the states that are parties to the relevant treaties, under the Geneva Convention, the Refugee Convention, but also under many other human rights instruments, including, of course, the Covenant on Economic, Social, and Cultural Rights. So clearly, countries are facing unprecedented challenges, but refugees too. And the need for a comprehensive approach to refugee protection and public health is as pressing as ever. And I'm very pleased today to have two leading experts in this area. They will address manifold challenges encountered by refugees during the COVID-19 pandemic, and they will give their perspectives on the lessons learned and also their views and good practices also from the angle of their own organization in ensuring refugee protection during the current health crisis. I'm very pleased to have here with us Dr. Madeline Garlick, Chief of the Protection Policy and Legal Advice at the UN Refugee Agency. She is leading UNHCR development and production of global guidance on refugee law and legal advice to states. She was also responsible for UNHCR liaison to the EU institutions for 10 years. She has served with the UN in Iraq, Kenya, and many other places across the world. And I'm very pleased to have you here today, Madeline. The second keynote expert and speaker is Dr. Santino Severoni. Dr. Severoni is director of the Global Health Migration Program at the World Health Organization, at the Office of the Deputy Director General in the headquarters here. He is a medical doctor, health economist with more than 24 years of experience as an international senior advisor and executive. And since last year, after several major positions, he was appointed director of the Global Health and Migration Program to lead the World Health Organization work on health and migration. So I'm very pleased to have both of you because clearly talking about refugee protection in terms of COVID-19, there is a need for a comprehensive, articulated vision from the two most relevant UN agencies in this area, namely UNHCR and the World Health Organization. I will stop now, and I'm very pleased to give the floor to Madeline Garlick. Thank you very much.
Thank you very much, Professor Chetail. And let me just say what a pleasure and a privilege it is to join you today, and with an audience of people from all around the world, with whom I'm looking forward to a lively discussion following our remarks. We are marking, as you have said, in a few weeks' time, Vincent, the 7th decade since the adoption by the General Assembly of the 1951 Convention relating to the status of refugees. And what UNHCR is underlining in this context is that we continue to see the ongoing relevance and need for the 1951 Convention. What we have seen, however, over the past 12 months, certainly, is that many of its tenets and principles, alongside principles of human rights, have come under considerable strain as a result of the many challenges that states around the world have experienced in the context of the pandemic. So I'll speak to you today about a few of the specific refugee protection related challenges as we have observed them. For this purpose, I will present a few slides, and I'm just hoping now that I have scope to share my screen. Please let me know if you can see it. I hope so. Not yet, if I understand well. I think it's coming. Sorry, I'm doing my best to master the technology, as I said today.
No worry. I mean, this is excellent. We can see now the slide.
Very good. Okay, so let me start the slideshow from the beginning. So indeed, as I've mentioned, I would like to highlight a few of the challenges that UNHCR, working together with its partners, have observed in this context. But perhaps before doing so, I can also just mention some of the statistics that UNHCR has just published in the last couple of days on the occasion of World Refugee Day, where we have released the latest figures regarding displacement worldwide. And this, of course, is a sobering picture because it shows us that as of the end of 2020, 82.4 million people worldwide were in displacement. And this, of course, is an increase by 4% from last year's total, which shows us indeed that the challenges we face in this area remain very significant, notwithstanding the restrictions on freedom of movement that we saw and movement across borders as a result of the pandemic. So sorry, that's a typo. You have there that should be 24 million refugees under UNHCR's mandate, alongside 5.7 million Palestine refugees under the mandate of the UN Relief and Works Agency. We also have some 48 million internally displaced people who've been recorded last year. So by far the bulk of the people who have been forced to flee are remaining within their own borders and are continuing to need protection and assistance in many cases. Noteworthy also amongst these statistics, perhaps, are the very modest numbers that we have seen of people who've been able to find solutions over the course of the past year. Some 251,000 refugees worldwide only were able to return to their countries of origin in safety and dignity last year, which is a drop by some 2/3 of the figures we'd seen in the year before. Some 3.2 million internally displaced people, but again, a significant decrease from the previous year. Only 34,500 refugees were able to resettle in third countries, offering them places, which is well under half of the previous year's total. And these limited numbers of people able to find solutions very much reflects the challenges we've seen in the context of the pandemic and highlights the urgency of ongoing efforts, including in the context of the Global Compact on Refugees, which emphasizes the importance of solutions for states and partners to really redouble efforts to try and improve this, because otherwise we run the very significant risk that many more millions of people are going to be stuck in protracted situations in years to come. Another challenge to highlight here in this connection is that we continue to see, unfortunately, a very significant imbalance in the numbers of people worldwide who are displaced, with some 85 or 86% of the world's refugees in regions affected by conflict or other crises, or low or middle income countries. And so close to 1/3 of them are in the least developed countries as defined by the United Nations. So this really means that close to 9 in 10 are living in areas or countries that are facing significant challenges. And again, the top refugee hosting countries show us that there are many in that number who are ill-equipped to address many of the challenges around protection and solutions. There's only one European country, of course, in that group that is highlighted on the screen. And a number of these countries, including Sudan, including Lebanon, including Iran, really facing very significant challenges addressing the needs, including health needs of their own populations, as well as those of refugees. Vulnerable situations continue to exacerbate, particularly for the world's refugee children. And a grim milestone to note in this regard is that 1 million refugee children were born into displacement this year, once again highlighting the importance of more efforts to ensure that responsibility for refugees, and particularly for finding solutions for them, can be more evenly spread and taken up with the countries that are best equipped to contribute to that. So moving into some specific challenges we've seen in connection with COVID-19, I've listed there a number of the categories which I will take us through during the course of my remarks this morning. Border closures and restrictions on freedom of movement, including attributed specifically to the pandemic, but also continued restrictions on movement that appear to be related more broadly to other policy goals. Mandatory measures to limit infection spread, testing and emergency medical care, and closures of hospitals and enterprises that have had impact on availability of protection for many refugees. So specifically, it's useful perhaps to highlight for those interested in this area, UNHCR at the very beginning of the pandemic has issued a set of legal considerations on the question of access to territory in particular. And this was really days after the WHO declared that the pandemic was a public health emergency of international concern. We saw already states moving to place limits on entry at their borders and saw the very real risk that this was going to mean, that rights would be violated and refoulement would be a very real danger. And so we issued these legal considerations that are in the public domain, where we acknowledged very clearly that states do, of course, have the sovereign power to regulate the entry of foreigners to their territory, but that these need to be undertaken in a way that doesn't prevent people from exercising the right to seek and enjoy asylum under international law, and specifically that this could not be done in a way that violates the customary international legal principle of non-refoulement, which of course binds states party to the 1951 Convention and other refugee instruments, but also non-contracting states as a principle of international law. And HCR highlighted in that guidance that states, of course, can take measures to manage the public health risks they perceive from the entry of third country nationals. But we highlighted that these must be done in a very measured way. They must be non-discriminatory, must be necessary and proportionate, as well as reasonable measures that specifically could serve to protect public health. And measures going beyond this would run the risk of being contrary to international law. Focusing specifically on border measures, I note that Professor Chetail himself has published a very interesting article on this that I would commend to readers. And there, as you've put it very well, Vincent, international human rights law provides a clear-cut answer that the rule of law does not stop at the border, nor in times of emergency. And so UNHCR in that connection has been monitoring closely the ability of people to enter at borders, and specifically people seeking or in need of protection. And we note that as of today, we have some 125 countries that have either fully or partially closed borders. Positively, that's a decrease from the 160 that we saw at the peak of the pandemic. Unfortunately, we still continue to see some 50 states worldwide who have made no exceptions to their border closures for asylum seekers. Positively, we have some 99%, so approximately 99 amongst those who have continued to provide the scope for people who are claiming asylum to be admitted exceptionally, and for them to be subject either to testing, to quarantine, or to other measures which can ensure that the right to seek asylum can be respected in a way that also safeguards the public health of receiving communities. And we've sought in the course of our advocacy and public outreach and work with states over recent months to highlight the very good practices we've seen on the part of many states who've done that. Also, soberingly, however, we do see instances where states either have denied access to their territory or in some cases have specifically undertaken measures to remove people from their territory in a fashion that has created a very real risk of refoulement. Access to asylum is a really important issue that you mentioned in your introductory remarks, Vincent. And there, indeed, as you have said, there's no legal right of states to suspend access to asylum procedures on public health grounds, notably where that means that they would be denying access to protection for those in need. We fully recognise that some states, particularly in the early weeks and months of the pandemic, faced very significant logistical and practical challenges. States wishing to ensure that there were not face-to-face contact and that social distancing and hygiene measures could be respected, which meant that interviews face-to-face were not possible, or that people attending asylum offices couldn't be continued for a temporary period of time. But really, there's no excuse for that having continued in a number of states where we still see that there is either only partially or no resumption of asylum processes. It's been very positive to see that we've seen a number of states adapting to the constraints of pandemic and public health measures, including through introducing remote registration processes, remote interviewing, and significantly increasing their innovative use of technology. This, of course, has been more challenging for some states with fewer resources to do so, but it's an area where UNHCR, including also with the help of states who have been ready to twin and to provide capacity development help, have sought to step up and to really ensure that this is possible also for states who may not necessarily have the resources to do so. This remains an ongoing challenge, to be entirely realistic, because of course we also see that some of the countries in the world, notably those in crisis regions and least developing countries in particular, also face major challenges around internet connectivity, which makes technology an issue. But work has to continue in this sphere as a matter of urgency. Aware that time's passing, I'll highlight a few other key elements. Solutions for refugees, as I've noted, has been also significantly hampered over the course of the pandemic. In some cases, this has affected voluntary repatriation movements, where countries of origin either have declined to allow their nationals to enter, or who have put in place unreasonable or unnecessary health restrictions or constraints. In some cases, UNHCR has sought to try and address this and ensure that reasonable health measures can nonetheless be respected, that states are given support to enable testing and quarantine measures. But we've also seen some instances, unfortunately, where this appears to be a case of states seizing on the pandemic as an excuse for putting such barriers in place. Resettlement initially was effectively stopped, where departure flights in particular were no longer possible. But it's been very good to see that resettlement countries have stepped up in the meantime, and most have resumed that. They've also introduced much more flexibility, which is very good in the selection processes. We now see remote interviewing and selection in a way that never happened before. But it remains a very significant area where we need more to be done on the part of resettlement countries, as well as looking to more countries in the so-called global north to undertake new resettlement programs, because the need for third country solutions, for safety, for people who can't find that in their own regions really continues to be very urgent. Let me also highlight the area of detention as a very significant challenge, because what we have seen in many cases is that detention of asylum seekers in overcrowded facilities in particular, where hygiene may be either difficult or unattainable, has led to the exposure of people of concern to a heightened risk of infection. And so we've been glad to see that some states have acknowledged that this is a situation in which it's been more appropriate to turn to alternatives to detention, to release people where there's no danger to public security. And we've actually sought to build on this and to encourage states to look at expanding their use of alternatives to detention, in line with our overarching goal of highlighting that detention for asylum seekers who have not committed any crime, by and large, really is not needed and is not going to be a strategy that achieves states' goals. We've also, of course, seen very significant impacts on livelihoods of persons of concern. Economies worldwide have been affected by the pandemic, but in many cases, it's asylum seekers and refugees who have work in the black economy or in precarious contracts who have been the first affected by the results of economic slowdowns. And so what we've been seeking to do, of course, is to encourage states to find ways to increase scope for people to work lawfully where that hasn't been possible otherwise. And we've also worked with international partners to establish specific livelihood programs. What we have seen is that in some cases, states have been ready to allow refugees and asylum seekers to work in the health sector, and thereby to contribute to not only better health outcomes for refugees, but also to the public health needs of their own communities, which in some cases has led to a more positive perception of asylum seekers, a positive outcome once again. Worldwide, there's been a spike in sexual and gender-based violence in the context of the pandemic. This, of course, appears very gravely across all of society, but we have noted in particular that UNHCR's persons of concern particularly have been affected by this. This is people who in many situations are under pressure, who are in stressed environments, and the effects of lockdown have been that risks of violence have soared astronomically. So we've seen a tenfold increase in the number of calls to our GBV hotlines over the course of recent months. So that's required us to seek to step up our efforts, also work more flexibly, including through the provision of online support, counselling, advice services where we could. But it remains a very significant issue on which we really need to do more and where we need more support from states and partners to do that. Let me just perhaps move on in this connection also to the risk that has been highlighted also for internally displaced people by some very good documentation and research by the Global Protection Cluster. We've really seen a very significant increase in susceptibility to exploitation and to the risk of trafficking that has come about in the course of the pandemic. As people's normal sources of livelihoods have been cut off, many of them increasingly desperate, have turned to negative coping strategies, which have meant that they have been led into trafficking situations, which of course remains a massive human rights violation where neither the international organizations nor states are effectively doing enough at this stage to combat it. So really this is a key area where we're going to continue to need to invest over the months to come. That shouldn't be allowed to drop off the radar just because we may see some relaxation of measures and some improvements in the health situation in some states worldwide. So perhaps turning to some of the lessons learned, which I hope we can definitely speak about in the discussion today. So what HCR has highlighted very clearly is that non-discrimination in access to health services, including to testing, including to treatment, including to vaccines, is absolutely vital. And we've pointed out, notably in those states where there's been some hesitation around this, this is actually in the interests of host communities as well as persons of concern. If refugees are at risk, then this means, of course, that infection, which does not discriminate, is a much greater risk for the entire community. So there's simply no rationale for making a distinction in this case. Being prepared, having greater measures in place to step up health capacity is another area where we've learned lessons. HCR for years, of course, has done a lot around preparedness for conflict and other kinds of emergency. But what we see now is that it's both ourselves and our partners, including a lot of states who've got fewer resources to have early warning and preparedness systems in place, really need to have this as a matter of existential need. And so we've had increased acknowledgement of that, but the resources and the know-how to do this needs to continue. Limits on measures to address public health concerns, as I've mentioned, need to respect legal parameters, and this remains crucial in all parts of the globe. And we need systems in place that are going to respond to the varying needs of different categories of people, which may vary according to their age, to their vulnerabilities and other factors. A few other key points there. We see the benefits that are clearly gained where we involve persons of concern, refugees, asylum seekers, stateless, and internally displaced people are involved in discussion about what measures can be taken. This has been clearer than ever in the course of the pandemic, where it's these people who are experiencing their challenges, who can diagnose and can identify problems most clearly and accurately for us, but who also often have the know-how and the experience and the insights to be able to identify possible solutions. The need for a special attention to children's need amongst other groups, particular ongoing attention to other health needs, which have in many cases sadly been neglected, including mental health, which has been a major ongoing challenge during the pandemic, and the ongoing urgent need for multilateral efforts, as well as continued adherence to refugee protection principles, including the 1951 Convention. Looking forward to the discussion. Thank you again so much for the opportunity to take part today. And perhaps let me finish with a quote from the High Commissioner, who underlined just a few weeks ago that in the midst of all of this, what we really need is courage and determination, and not a reaction governed by fear. Thank you very much.
Thank you very much, Madeline Garlick, for this very clear, didactic, and quite impressive overview of the many different challenges related to refugee protection. And as you rightly mentioned, the challenges are not necessarily legal from the angle of international law, because clearly international refugee law has highlighted its resilience and relevance to protect refugees in times of pandemics. But of course, the practice on the ground, the operational and humanitarian challenges are huge. And there is more than ever a need to develop evidence-based policies governed by the rule of law in the interest of everyone. So this is not an issue to be in line with international law and an issue for lawyers and so on. This is an issue for everyone. I mean, clearly both legal and policy considerations are converging in acknowledging the need for a truly inclusive approach to refugees in times of COVID-19. And now I'm very pleased to continue the discussion and this presentation with Santino Severoni from the angle of the World Health Organization, because clearly this is also an important issue to be addressed, refugee protection to be addressed by the World Health Organization. Dear Dr. Santino Severoni, the floor is yours.
Thank you, Vincent. Thank you for having me with you today and offer me the possibility to share the public health perspective. I like to underline that in WHO probably we don't know much about refugee or migration management, but we do know pretty well the public health implication of population movement. And with my few sharing of today, basically as a food for thought for later discussion, I would like to have a bit of reflection on the legal framework, really building on what Madeline has been presenting at the beginning, how this is impacting the health system, especially in the access, the political atmosphere, how this is really relevant then for shaping up the health systems. Then few element of key public health issues we are confronting every day when we are addressing the health implication of population movement and COVID-19, which is the big theme today. So if I ask you to recall the first slides presented by the UNHCR colleague at the beginning, you have seen a list of terms. This is very important because behind that terminology, there is a tendency, and I'm not a legal expert, but there is a tendency to well define legally what do we mean, what kind of population we do mean with that. And from the public health point of view, what is the result? That the definition define also the legal framework. Imagine that in certain cases, the legal framework for access to health is described within the constitution of the country. So imagine how strong is this element. Secondly, the shape up of the system at country level is a political decision. Is a decision which is made by the government according to certain principle that could be more based on public health evidence or more on political opportunity, but certainly the full mandate responsibility of shaping up the health system belong to the state. There is no derogation, even in the context of European Union. There is no delegation to EU to tell to the country how the health system is supposed to be shaped. What does it mean, this one? It means that all those legal attempts to define people, and if you're talking about refugees, those terms are, I'm oversimplifying, intermediate stage of a process of a certain length, which lead into the refugee to get full entitlement to be protected or recognized to be protected by this state, which has been ratifying the UNHCR Convention. And here is the first caveat. Not all member states have been ratifying the UNHCR Convention. So the level of protection might be varying from country to country. As a consequence, the legal entitlement to access to public health. But unless there are corridors, unless there are very well organized modality to protect refugees, those escaping when they are at the stage of requesting asylum. Basically, a big number of those requesting asylum, they tend to escape, they tend to move spontaneously. So the first reaction of the government being in very broad sense of view, the migration policy based on border management, they tend to be screened in order to identify those which are objectively in need of or entitled to request asylum. Then they enter into a process which can last even 1 year, 1.5 years. It's not necessarily a very fast process, where the recognition of refugees is going to happen at the later stage. All those mechanisms, all those administrative and legal structure defining a different level of entitlement of access to the health system. In fact, if we're going to again oversimplify, if we look to the landscape of the health system worldwide, we see 3 groups of countries. Countries which they offer only emergency care services, which is the majority, unfortunately. Countries which they offer emergency plus. So they recognize that there are some health conditions which they need to be addressed before they are becoming an actual emergency. And then the smaller group are those which are basically having, we technically saying, a universalistic approach or universal health system approach. It means they offer full access to everybody, to all services. The legal framework or the adaptation, flexibility, or derogation, we have seen a lot of derogation ongoing during the COVID response, are directly linked to the political feeling, to the political vision. For the reason which I said before, we have experience, we have countries where the most successful Minister of Health that had been reforming the health system and rationalizing the hospital setting has been losing the elections at the next tournament, because usually to close hospitals or to play with the health system is always extremely politically dangerous for politicians. Also because the result of political decisions that tend to happen in a long period of time. So the political sentiment, the political approach tend to be extremely influential because tend to basically try to address the tummy of the public opinion. So those more irrational sentiments and vote collection. For this reason, sometimes the public health decisions we are observing, they are pretty irrational. And during COVID, in fact, we have seen countries, that was quite interestingly, that if we look at the behavior of countries based on the public health approach to respond to the pandemic, to address the public health measures to respond to the pandemic, we have seen very much a kind of uniform, consistent approach across all countries. When we look at the approach towards mobile populations, refugees, irregular migrants in general, we have seen a very complicated picture. First of all, there was not this, let's say, public health driven approach. This was very much politically driven. So there were countries which they decided to have a universal health coverage approach. But here I like to ask you to stop a second to reflect. The inclusive, the universalistic approach of public health is not an issue of charity, it's not an issue of political decision for convenience. It's a public health necessity. And the COVID-19 pandemic has been proving what we are preaching since ever, that if you want to have effective public health response or measures in relation to the benefit, the health outcome of the population we are serving, we should be as much as possible inclusive. Means we should supposed to not to leave anybody out of our outreaching, because leaving part of the population or having a population underserved means creating a potentiality of public health threats that can appear later on if you're talking about communicable diseases, non-communicable diseases. So really the reaching the entire population, it's a public health requirement. It's not an element of charity or to be good or to be practical for election reasons. So certain countries, they really went for that, probably because also the political atmosphere was more inclined to that approach. Other countries where the political atmosphere was not really comfortable with an approach telling to everybody, we are including all people in the territory, even those in irregular condition, means not defined legal definition, with a full access to health system. There were probably the majority, and those are countries which they move from exception to exception, from derogation to derogation, because at the end, again, the pandemic showed to them that you could not leave anybody out, either in the preventive stage or in the surveillance stage or in the curative part. The situation related to COVID also provide us interesting data in relation to communication, how the health system communicate. Now, I will, in a few seconds, take you through the different key public health issues we are confronting every day. And as you see, one of the main challenges is really to access the health system and to navigate the health system. And this is everybody's challenge, not only belonging to refugees. Allow me to explain you. I'm sure that any of you in the recent time might have a need to go for a medical test. And usually when there is this need in the family, what is the process? Usually over lunch or dinner, the family gathers, say, we need to go for a CT scan. Okay, do we know a good doctor? Do we know a good radiologist? Which hospital are we going to go? That is better. What is the waiting list? How much does it cost, the fee for those services? So this is access and navigation of the health system, which all of us, we are doing every day. Imagine when you are overlapping to the need of navigation, also element like language barrier, cultural barrier, access to information, training capacity of the healthcare workers to deal with a diverse type of patient population. So all those are enormous challenges. And again, during COVID, we realized that the element of communication, which was so important because all of you, all of us, we've been overexposed. In fact, WHO also start to be concerned about the infodemic related to COVID, the access of information and distortion of information. In the case of this part of population, we were really observing poor level of information sharing in different language and or effort of the country to enrich websites with informations also for non-national population. For this reason, we thought to also go and scan what happened in the refugees and in this case also migrant population. We conducted a survey interviewing 30,000 refugees, migrants, regular, irregular, in about 170 countries around the world during the acute first wave of COVID-19 pandemic. And it was interesting to see the perception of the risk and the perception of the health conditions of this population. To me, was the most painful finding was to see that the most vulnerable are the most underprivileged. Means that those living in the most precarious conditions, maybe without papers or even not having a proper shelter where to protect themselves, well, they were the one refusing or avoiding to seek medical care, even in the case of suspect one of them or the family contracted COVID because of incapability, lack of financial means. And this was about 30% of them in those conditions, and about 20% of them for fear of deportation. Because again, and I'm connecting again to the introduction of the legal framework and the political approach, the border management also implies that who breaks administrative rules like passing a border without documents might be detained, and the system in most of the high-income countries is detention-based for all those population, unless they are not refugees, they are not recognized asylum seekers. The other element was the really massive in the survey was to observe the massive impact of fear among this population, again for lack of information, because in the case of refugees or population in irregular condition living in detention or camp-like settings, the uncertainty for the future was also accompanied by a very fragmented amount of information or guidance. In most of the cases, they were provided by non-governmental organizations working in those settings, but the level of information provided by the governments hosting those camps was not consistent with the needs or with the public health standard that we were recommending during the acute phase. Interestingly, those people that were consulting through, now it's easy to have IT facilities, so they were following instruction information at home. And this was an additional complication because the epidemiological situation at home not necessarily was corresponding to the situation in the country they were living. So basically, this was creating a mismatching of behavior or capacity. But in all those cases of detentions or management of this group of population in condition of control or semi-control, we detected condition of overcrowding and poor living conditions where the basic public health recommendations of keeping safe distancing, physical distancing, or washing hands, having access to water was practically impossible. Then there was we were very concerned that this political sentiment, the political sensitiveness on this topic might influence also media and then public opinion in stigmatizing moving people in spreading the COVID-19, the coronavirus. This was particularly for those which they were forced to move in irregular or an emergency situation, even during the lockdown, because was declined. But you have seen from the data before, people have been escaping from dangerous situation and asking asylum or migrating irregularly and so on. So basically, we were afraid about this attempt. We noticed some attempts of the media, but then again, the public health pressure was such that this didn't actually succeed. But still, we went to study the situation, and it was interesting to see that in case of very controlled or close detentions or camps or camp-like setting, in many cases, the incidence of coronavirus infection was lower than the rest of the population, because basically those people are not free to move, so they were sort of isolated. But the high risk was the introduction by the worker moving into the camp and maybe bringing the virus in case. In those few cases where this happened, actually the infection spread really massively and rapidly. Differently was for open centers, for centers where the asylum seeker is free to move in and out because into the process. In this case, the prevalence of infection was mirroring perfectly the prevalence in the country where the asylum seeker or these centers were located. Then the story, but here we are talking about those which already they complete their own process of recognition. They're having papers, they are working, they're having a job, they are studying. We also collected epidemiological data where we have seen that usually people that migrate or forcibly move to a new country, once they are settled down, once they get a paper, they tend to move into let's say, lower or less skilled type of jobs. And during the pandemic, we detected that those people that were the one ensuring the functioning of transport, of food chain, of delivering, of cleaning of the roads, or collection of garbage. So basically, or healthcare workers. So basically, they end up to be, in certain cases, more exposed to the risk to contract the COVID. We don't have data. We cannot say that mortality was higher or there were this disproportionate level of mortality among certain group of population than the rest. This mostly because there is no so high disaggregated level of data collection that we can draw yet a picture in this regard. So by concluding, I want to just to build up on what I said up to now to resume to you what are the most common public health issues we are confronting when we are dealing with the Ministry of Health. The first one, as a result of all this story, is when we are going to a country where we are meeting with a minister and his team. In many cases, we've been observing in the past, and I like to underline that, we've been observing in the past, because thanks God today the situation is changing, is changed in many contexts, that health sector was not having capacity in place to deal with a diversified type of population. Even worse, in certain cases, Ministry of Health said, this is not my area of competence. This is Ministry of Foreign Affairs, this is Ministry of Interior, Ministry of Labor. It's not, it is a big mistake because, as I mentioned, there are important public health implications related to population movement, forcibly or spontaneously moving, but certainly the health sector cannot be operating based on a legal paper or a nationality, but need to have really a universalistic approach. The second element is the economic impact. This usually is the most easy play card for politicians when they want to say that we cannot have an inclusive approach of the health system because we are spending too much money, it's costing too much. Maybe at the beginning can be an investment, but health is always an investment, even when it serves only nationals. So it's always an area where we need to invest for the preventive and curative part. So we are not looking to in a business-oriented type of approach if health sector produces the income. The income is the well-being of population. Then people, because are healthy, they are productive and contributing to the revenue system and so on. The access to a system, I said a lot before, and the barriers, keep in mind, might be related to how the health system is designed. Imagine a system which is mostly privatized or belonging to private providers is more rigid in terms of selecting who can access, because need to be able to have the financial capacity from a universalistic type of system, but still there are also barriers related to the quality of professional training of healthcare workers, but also there are barriers related to the working conditions of healthcare workers, because if you have an understaffed health facility which has to access a large number of patients every day, will have less time to really do the job in an effective way. And imagine if you put there also a patient with a language barrier or other sort of individual type of barrier. Must to be said that to overcome those difficulties, there is a quite new type of healthcare profile that we are now loading the health systems around the world, like cultural mediator, translators, is pretty common approach. Then the health risk, really defining the health risk and ensuring that the health system, receiving countries, and the health system of country of origin are well prepared. Well, you will be surprised because this is looking obvious, but in reality, as even the high-income country showed to us during COVID, they were not prepared for a pandemic. Well, this is a routine also when we are talking about mobile population. Even in the case of force movement in case of refugees and asylum seekers. I like to say that I was working in the European region previously, and during the 2015, but even before, when there were large movements from Northern Africa, we were assessing the health system of the receiving countries, transit countries. It was astonishing to observe that very advanced countries, high-income countries, they were having national preparedness plan for everything but large movement of people, even for a football match, but not for large movement of people. So really innovate and assist countries to make sure that they're having capacity in place, that they consider the scenario of large movement of people and to properly size hazards. How? Through risk assessment, because there is no necessary movement of disease, spreading of diseases, if there is not a gradient of disease across borders. Communicable versus non-communicable diseases. Big concern about Ministry of Health is always the spread of communicable diseases. So our recommendation is always that countries need to have an effective, functioning surveillance system in place always, not only for migrants, only for refugees, only for COVID. Surveillance need to be always there, and very active and passive surveillance. Health information system need to be there, collecting those data, reading those data, and then you see that movement of spreading of communicable diseases is not a prerogative of mobile population, is a prerogative of all of us if we are moving around, but with a difference that the risk assessment can tell you in advance if you have refugees escaping from war, and in the camps at the border there was an outbreak of cholera. Risk assessment tell you exactly what to do and to pay attention to those communicable diseases. The issue of NCD, of chronic diseases, is almost unaddressed, and mental health. And this is really a big problem, because there is the spending, there is the cost for the society, there is the challenge for the health system when we are talking about really burden of the health system. The universalistic approach I mentioned, this political change and attitude according to the political sentiment. The research, data collection, I mentioned briefly with the health information system, this is paramount. The reality, even during COVID response, we realized that health sector is really crying for lack of research on those particular conditions. You need to understand that people on the move, they are having a very complex situation they are confronting with. And even in the context, you cannot generalize, even when you're talking about refugees, so people which have the protection paper and they are settled, they're having a job and so on, there are different type of population. Basically, it's mirroring the difference that we see into the population. And epidemiologically, this is relevant, and to have data, to have information about the different contexts, the different impact of life course on life of people is essential to then inform policy making and information for service provision. Thank you very much, Vincent, for this opportunity to share a few considerations related to public health, and happy to answer to any question.
Thank you very much, Dr. Severoni, for this very interesting and inspiring presentation.